So I'm very pleased to welcome our assistant clinical professor, Benjamin Schneider, here from UCLA. He's in our Department of Psychiatry and Biobehavioral Sciences, and he's also the Associate Director of the Child and Adolescent Neurodevelopment Clinic and the Medical Director of the UCLA ABC Partial Hospitalization Program. So this begins our section on psychopharmacology. As before, I will ask you to save your questions for Ask the Experts or during the break. We have note cards outside, so please write your questions on the note cards. We have a basket for them, and we will collect them and answer them as best we can. Dr. Schneider will be speaking to us on, is there a pill for that? What do we know? What we know and don't know about ASD psychopharmacology. So join me in welcoming Dr. Schneider.
Thank you so much. I'm delighted to be here with you today. In the next 25 short minutes, I'm tasked with providing an overview of the psychopharmacology of autism and related disorders. Dr. McCracken will be coming up next talking about the cutting edge, which I think is probably a much cooler title than what I was considering, the dull blade. Obviously, though, this is no small task, so without further ado, let's get after it. I have no relevant financial relationships with commercial interests to disclose today, but I will be discussing off-label use of medications. So there's no subject in which anyone becomes an expert after listening to someone talk at them for 25 minutes, but I hope when I'm done you'll have a good sense about what we know well and what we, I guess, sort of kind of know, but most importantly, how to be an educated practitioner or consumer or patient or parent or advocate or you name it. So we'll highlight medications as a treatment tool for behavioral or emotional challenges with an emphasis on treatable targets. I'll comment just briefly on the assessment of behavioral and emotional challenges as part of prescribing practices. Again, we'll delineate what we know and what we sort of know and what we just truly don't. And then I'm going to highlight some examples of both positive and negative studies that have influenced prescribing changes over the last few decades. So why is this important and why am I showing you such a busy slide? We prescribe to kids and adults with autism a lot. This is just a sampling of epidemiologic data. As you can see, rates of prescribing are quite high across the board. It's beyond the scope of this short talk to discuss all the factors associated with higher psychotropic use, but for our purposes, it's enough just to note that we use quite a lot of medication in this patient population. And before we move too far ahead, I'm just going to talk briefly about some of my rules to prescribe by. I want you to have an understanding of psychopharmacology's role, specifically that I think about it along two fronts. I think about treating symptoms, but I also think about creating space for therapy to be more effective by targeting competing or otherwise disruptive behaviors. I want you to be able to distinguish what we really know from what we need to learn more about, and always, always consider communication deficits in your prescribing and perform a functional analysis when possible. Remember that behavior is communication. It's important to consider multiple sources for the problem and refer for further assessment if it's needed. Take into account the role of family functioning, factors that can exacerbate behaviors or serve to reinforce behaviors, physical health, coexisting mental health disorders, sensory factors, and of course, daily living skills. Psychopharmacology in the absence of a thorough assessment is likely to miss the mark, and so knowing that these patients are expected to experience perhaps even more side effects than otherwise typically developing patients is, I think, key. And finally, knowing the limits of the literature. There are blind spots, of course, and we need to keep in mind not only what's been studied, but the fact that useful potential medications may get short shrift as there's little incentive to study them now. And then, of course, the question that I ask of every parent and every provider is how are you going to measure whether or not what you're doing makes sense, is working, is causing problems? It's simplest, if you can call this simple, to think about targets in terms of zones. Here on the right, you'll see irritability and ADHD, which I'm going to highlight as two zones that we actually know a little bit about. We'll also touch on the core symptom zone, unfortunately as evidence of what we don't know very well yet, but still important to cover given, I think, lessons learned here can and should influence our prescribing practices. And very briefly, we'll touch on the upper left-hand zone of comorbidity. So we'll start at the start. The best established evidence base in medication for autism is specifically for irritability. There are only two FDA-approved medications in the treatment of autism, Risperidone and Abilify. And knowing pictures speak louder than words, I'm just going to show you about five or so slides, all to illustrate that these medications work well. If you continue the medications, they keep working. There may be more benefit than just irritability. And if you add behavioral therapies, then we've really got something going. So nobody has ever sat through, in the last 10 years at least, has sat through an autism lecture without seeing these two figures from the RUP study. The RUP study was 101 patients, ages 5 to 17. These patients were given risperidone versus placebo, and 69% of the patients in this study met responder status, which was defined as a 25% reduction in the aberrant behavior checklist irritability subscale, and a CGI, or a clinician global impression scale, of much or very much improved. And more importantly, almost 2/3 of these patients retained their responder status in the 4-month open label phase of the study. Figure 1 shows the mean irritability score on the ABC, and Figure 2 shows the percentage of children with a rating of much or very much improved on the CGI. And I've included two numbers here. I've included the effect size, which was 1.2, and the number needed to treat, which was 2, because they're not just good, they're really excellent in terms of what we know in psychiatry. Notably, there were statistically significant improvements in stereotypy and hyperactivity as well. We'll come back to this a little bit later. I don't tend to take this data and suggest that we use these medications to treat hyperactivity or stereotypy alone, but it's important to know that you may see additional benefits if you need to use these medications for irritability. This is for showing continued efficacy. This is the 4-month open label follow-up phase. So folks who were responders in the initial study and who stayed on risperidone tended to continue to have lowered ABCI subscale scores. And on the right-hand side, this is a survival analysis for children with autism who responded to risperidone and who were then randomly assigned to either get placebo or continued risperidone for 8 weeks. It's pretty plain to see that those who continued on risperidone, almost 90% of them retained their responder status, whereas those, excuse me, those randomized to receive placebo did not. Abilify is FDA approved as well, and I won't belabor the details here, but irritability subscale scores reduced, as well as did CGI, clinician global impression scales, for severity and improvement. This was replicated in a second study, thus unleashing the magical FDA approval. But here's where it actually starts to get really interesting. If you take these findings and you combine these treatments with behavioral treatments, you'll see even additional benefits. So this is a study in which patients were either randomized to receive just medication, in this study either Abilify or risperidone, or they got Abilify, risperidone plus parent training. And those that received Abilify and risperidone, as you can see, especially further into the study by weeks 16, 17, there was true separation in the home situations questionnaire. So if you combine these treatments with behavioral treatments, you're likely to see more benefit. The same sample as in the previous study reported got a second look, and this time specifically looking at measures of adaptive functioning. So this is, again, another research unit in pediatric psychopharmacology autism network study. We know that risperidone reduces maladaptive behaviors, and we know from the previous slide that the benefit is sustained and that adding parent training can further reduce maladaptive behaviors. But if we can actually show improvements in adaptive behaviors too, that would really be something. On the left-hand side, medication, either risperidone or Abilify alone, and on the right-hand side, combination medication plus parent training and behavioral therapy. Listed as the proportion gaining 6 months on the Vineland. So the Vineland is scored in terms of time, in terms of age equivalence. And you can see here the odds ratio, particularly in the domains of socialization and communication, go way up considerably in the combination group. So why are we not prescribing risperidone and aripiprazole to everybody? The side effect burden is considerable, and I'm quoting an old mentor of mine who always said, you don't give the prescription in a Big Mac wrapper, which is of course true, but it's an oversimplification probably, and it's important to highlight that these are very real, very uncomfortable side effects. Dyslipidemia and weight gain were common, and patients with higher baseline weight were more vulnerable to weight gain. Sedation was also common in the 2 largest controlled studies. An average weight gain of 3 kilograms in 8 weeks and of almost 6 kilograms at 6 months. Hyperprolactinemia was another reported side effect, although this seemed to decline with chronic treatment, although it remained high. And luckily, at least in these shorter-term studies, no significant differences in extrapyramidal or movement side effects between the treatment arms in the largest studies. The side effects for aripiprazole are very similar: sedation, weight gain, treatment-emergent extrapyramidal side effects, vomiting. And sadly, a review of longitudinal clinical data showed comparable BMI changes between risperidone and aripiprazole. This sort of goes in the face of the prevailing clinical wisdom in that Abilify causes less weight gain than risperidone, which I think is true for some patients, but perhaps not. This might be something that's unique to our patient population with autism spectrum disorders. Given the high level of efficacy of these two medications, of course, other antipsychotics are often used or at least looked at. Paliperidone has some open-label studies looking similar to risperidone. Haloperidol has several older studies that showed efficacy. However, risperidone still looked better in a head-to-head trial, and extrapyramidal symptoms with haloperidol are much more common. Olanzapine only has case studies and often open label with reported positive results, but weight gain and metabolic changes are considerable. Ziprasidone, again, open label, which has actually been very promising. However, you got to be mindful of the possibility of cardiovascular side effects, specifically with this antipsychotic. Open label evidence for quetiapine, lurasidone. I highlight lurasidone as every medication goes through several life cycles, and lurasidone a couple of years ago was in its promise phase, which is when we as psychiatrists say, we're going to start to use this a lot, and it's going to be great. It's going to have all the same benefits of Abilify and risperidone, and it's not going to have nearly as many side effects. And sadly, in a really well-done, fairly large study, that just proved not to be the case. And actually, they gained weight in that study too. Not as much, but acenapine and olanzapine only have case reports. This is another area of major relevance in current research. We know that Abilify and risperidone and similar medications may work well, but the metabolic burden is considerable. We often talk about metformin and topiramate as two medications that have shown efficacy in limiting weight gain associated with second-generation antipsychotics. I don't think we can yet throw these into the well-established category, but it's an area of current research with initial signs of promise. So perhaps if we can be mindful of the side effects of risperidone and Abilify and prevent some of the weight gain or metabolic problems, things would get a bit better. Very briefly, I'm going to fly through some of the other things that have been looked at, specifically for irritability as this first zone of impairment. Depakote in early case reports looked pretty good, but results are much more mixed in the very small randomized controlled trials. The other thing about Depakote is it requires quite a lot of laboratory monitoring, certainly at the beginning, but then again ongoing. And so you have to be mindful about whether or not your patient can tolerate that. Side effects are actually relatively similar to the atypical antipsychotics with behavioral activation, rash, sedation, weight gain, nausea and vomiting, also common. Lamictal, Keppra, oxcarbazepine, topiramate, all medications that have been talked about, looked at, used in case reports, only small randomized controlled studies for any of these medications that have not shown nearly the same benefit. Lithium perhaps has some specific syndromes and situations. I don't know why the bottom of that slide is cut off, so I apologize for that. But there may be specific genetic syndromes for which lithium has real evidence. I would also talk to you about lithium as a potential blind spot. This is not uncommonly used for all-cause aggression, and it has FDA approval for treatment of bipolar disorder. It may also have some additional benefit in neurodevelopmental disorders such as fetal alcohol spectrum disorder, but research specifically in ASD is limited, and so maybe this is one of those blind spots. Moving on to the next zone of impairment, hyperactivity, impulsivity, and ADHD. Hyperactivity and impulsivity are very common. We've all had patients for whom we have said, I could really make headway with these behavioral treatments if only I could get them to sit still for 5 minutes. The medications used here are stimulants, alpha agonists, atomoxetine, and a few others. Really everything starts with the stimulants. So this is again using the aberrant behavior checklist, but this is the hyperactivity subscale score as rated by both teachers and parents at baseline and at the best dose of methylphenidate during the crossover phase and then during an open label continuation phase. So as you can see, there's a significant reduction in symptoms both from parent and teacher rating scales. And here again is evidence that we may see further improvements beyond what we're specifically targeting. In this instance, you'll notice that social functioning improvements for patients with ASD, social functioning improvements for patients with ASD who receive stimulants. In in these figures, you'll see there are increased frequency of joint attention initiations in figure 1, increased frequency of total responses to joint attention in figure 2, better self-regulation in competing demands tasks in figure 3, and a higher proportion of time in which children were scored as being in a regulated affective state in figure 4, in children receiving methylphenidate versus placebo using a social communication measure. So very briefly again, stimulants at a glance. Methylphenidate is effective, although response rates are lower and discontinuation rates higher than in typically developing children and adults with ADHD. In the largest studies, 18% of participants discontinued, most frequently due to irritability. And a response rate of 49% in the RUP study differs greatly from the multimodal treatment of ADHD study in which 75% of children showed real benefit. There are no amphetamine studies to speak of, although these medications are still commonly used, borrowing from the methylphenidate data. There are small randomized controlled trials of clonidine and guanfacine, which have shown efficacy in improving hyperactivity as well, and these medications are commonly used. Strattera and Strattera plus atomoxetine and atomoxetine plus parent training have also been looked at. Although a word of caution here, you have to be careful about judging whether or not Strattera is working. It takes quite a long time before you may see the full benefit. I'm going to move on now to some core symptoms of autism. Though we already mentioned that antipsychotic trials showed some mild reduction in repetitive behaviors and insistence on sameness, this is actually an area that's been rigorously studied on its own. I bring it up today, sadly, not because we can tout the same successes, but as we've had with irritability and ADHD symptoms, but because I think the hard lessons are important as well. So initially, of course, there was I think, hope that these symptoms might be related to compulsions and anxiety. There are several open label trials that touted success with SSRIs, with reductions in compulsions, anxiety, aggression, et cetera. Controlled studies were mixed. And there was some hint, although, again, these studies were quite small, that SSRIs were both more effective and better tolerated in adults than children. And a meta-analysis in 2012, since this is cut off anyway, I'll let you know the results. There was a small but significant improvement in repetitive behaviors, but the authors concluded that there was significant enough publication bias, meaning the positive studies made it out there and the negative studies didn't, that it influenced prescribing practices. There are two very recent somewhat recent, I should say, SSRI studies in children with ASD, which have sadly both been negative. So Brian King and others looked at citalopram with 149 patients, and 149 patients in ASD medication studies is a pretty good number. And then there was the study of fluoxetine in autism with 158 patients. Sadly, both of these studies, as I mentioned, failed to show improvements in repetitive behaviors, and there were really high rates of side effects like activation, treatment-emergent aggression, et cetera. These are the figures from the citalopram study. The citalopram study, and as you'll see, failed to see separation between citalopram and Celexa. Why am I spending even relatively little time talking about these negative SSRI studies? Because here again is another example where we see side effects at rates that are far greater than we'd expect in neurotypically developing children and adults, and that, I think, does merit conversation. We think of citalopram actually as one of the medications that is sort of in the middle in terms of risk of activation amongst the rest of the SSRIs. So I don't think of it as a higher offender. And in this study in particular, citalopram was dosed fairly modestly with, I think, the highest doses in the max dose was 20 milligrams per day, and the mean max dose was actually 16.5 milligrams. So 97% of patients in this study reported at least one treatment-emergent adverse event. I had to put it in there. I cannot ignore that 86% of the people who received the placebo also said the same thing, which just highlights how complex this can feel for many patients and families. But still, energy level increased in 38.4% of patients versus 19% of patients on placebo. Anger and irritability at almost 25%. Aggression or hostility, again, almost 25%. Restlessness, almost 18%. Disinhibited, impulsive, or intrusive behaviors, almost 18%. When I say to a family, I'm going to give you a medication and there's a 25% chance it's going to make you more angry and irritable, that can be a hard sell. And so I do think it's really important that we take the time and say, look, if we're treating anxiety, and I'll talk about this in just a moment, it's worth a try. But if we're hoping to see a reduction specifically in repetitive behaviors that are not related to anxiety, we're less likely to see the benefits. This brings up the topic of comorbidity. Another reason to bring this up is to highlight that this high side effect burden in our patient population on a medication that is actually thought to be relatively well tolerated in typically developing patient populations is burdensome. We're basically borrowing the literature from non-ASD populations and deciding how to treat other common comorbidities such as mood disorder and anxiety. But comorbidity is common. We think as many as 70% of patients with autism have at least one comorbid psychiatric condition. There's variable symptom presentation. So for example, we already saw these overlapping zones or overlapping circles. Anxiety can present as increased repetitive or sensory behaviors in patients with ASD. And we're not that good at coming up with comorbidity diagnoses. So diagnostic concordance from community samples versus clinician-administered semi-structured interviews highlight that we often misdiagnose or fall prey to diagnostic overshadowing. And so it is really important here again that clinicians become really adept at identifying comorbidity so we can safely and effectively prescribe medications to our patients. The anxiety treating agents in ASD are the same as they are in otherwise typically developing patient populations, including selective serotonin reuptake inhibitors. One recent meta-analysis, although, showed that the psychopharm studies were mostly descriptive and open label, and sometimes didn't even specify the anxiety phenotype. And again, behavioral activation, same as in the citalopram study, was a limitation. A few open label and case series on clomipramine with mixed results, but like SSRIs, maybe a little bit better tolerated in adults than in children. Again, case reports on buspirone or Buspar, mostly open label, and a relatively lower side effect profile. Mirtazapine has been looked at in case series and open label reports, and perhaps there's a hint of promise for problematic sexual behaviors associated with ASD with this medication as well. I can't get through a psychopharmacology talk on ASD without at least one slide on sleep. In our clinic, actually, we kind of took a poll because the evidence is so limited about what are our various sleep algorithms. And of the 8 clinicians in the clinic, we came up with 8 different algorithms. But everybody's 1, 2, and 3 were the same. Number 1 for everybody was behavioral management, because medications ain't gonna do it. Number 2 and 3, melatonin and clonidine. And everything after that has really not been well established or well studied, in particular in children. And so borrowing from what we know with other medications, this is a patient population that's more susceptible to medication side effects. And so experimentation is, you just have to be very, very careful. Finally, and very importantly, every parent, every patient, every advocate should keep an eye on medication side effects. Those who've worked with me before have probably heard me say, if you ever encounter a psychiatrist who tells you that the medication they're prescribing has no side effects or 0 side effect potential, you should run away. No medication has zero side effect potential, but it's more important that your clinician, your provider, knows what they're looking for and tells you how they're going to look for the side effects, how they should be monitored, and then what to do about it. So sedation and lethargy, growth changes, cardiovascular side effects, extrapyramidal side effects, hyperglycemia, hyperlipidemia, hyperprolactinemia. All of these are things that we need to be mindful of and watch out for. And so in this slide, which I've borrowed from Dr. McCracken's recent chapter, these are the various medications that can cause these side effects, the frequency at which they should be monitored, and your strategy for monitoring. And this is incredibly important. So, overview and takeaways. We have pretty strong evidence for treatment of irritability and hyperactivity. Side effects are common and require monitoring. Comorbidity is likely treatable, though there's less evidence specific to this population. And accurate diagnosis is really the challenge and the must. Systematic monitoring is incredibly important, both for benefits and for safety. And so I implore you all to ask, how are you going to measure? How are we going to make sure this is working? How are we going to make sure we're not wasting our time? How are we going to make sure that this is safe? How are you going to measure? And finally, this is just a little plug for the Parents Medication Guide, recently put together as a joint collaboration between the Academy of Child and Adolescent Psychiatry and the American Psychiatric Association. I think that this is really well done and includes great wisdom for parents in deciding when and how to consider medication. And then it also includes this medication tracking form, which can be really, really helpful, not only for patients and families, but for their clinicians to know what's been tried and how well those trials were conducted. And here's a totally unreadable references slide, which means I'm done.